So, Jyoti, I have a question for you regarding the myeloproliferative neoplasms. Oftentimes, patient asks, why do I have an MPN? How did this myeloproliferative neoplasm arise?
So that's a great question and one that's been of significant historical interest. There was a chap called Willem Damaszak who, over 50 years ago, predicted that these overproduction of cells that switch on in some individuals to cause myeloproliferative neoplasms, but in not other individuals, these cells are responding to some sort of stimulus that is driving those cells to make more cells, more than the body needs. And over the last 20 years, we have discovered many of those causes. And what we believe is happening is that our blood is produced by blood stem cells, or the more scientific name for them is the hematopoietic stem cells. So these are the parent cells in our bone marrow that are responsible for us making all the different types of cells, red cells, platelets, and white cells that carry out the functions. And what we believe is happening is that as those cells are doing their job, dividing, making more blood, there is a mutation that occurs within the DNA of those cells. Sometimes that can occur whilst the cell is dividing. Other times it can just occur at any point. And if that mutation then suddenly makes that cell switch on permanently, such that it is constantly producing blood cells, as opposed to only when required by the body, you can get to a situation where you're making more blood cells than you need. So those mutations have been discovered over the last 20 years in at least half of patients with polycythemia vera, essential thrombocythemia, or myelofibrosis. The mutation responsible occurs in a gene called JAK2. When that JAK2 gene gets mutated, the cells go into overdrive and produce more cells than we require, red cells in particular, but also platelets. Subsequent to that, we discovered a mutation in a gene called MPL that makes the cells again much more prone to making more blood cells. And about 10 years ago, the third major mutation that drives these cancers was discovered, and that's a gene called CALR. So, about 90 to 95% of cases, I'd say, individuals have been found to have a mutation in one of these three genes. And in acquiring these mutations, those cells then start to make more blood cells.
So I guess following up on that, we know that mutations, and you beautifully described the three classic mutations that drive these diseases. Why are those occurring, and when are those occurring in life? Are these things that, there's a reason for them to occur? Patients are having certain exposures, or are they something that occurs by random chance? Do we know the answer to that question?
Yes, an area of active research. So there are multiple studies that have shed light on that. Within our team, we were able to identify that some of these mutations, particularly mutations in the JAK2 gene, they can occur very early in life and during childhood, early adulthood, even earlier. And what happens is those cells just have a very mild advantage over their neighboring cells, such that for every year that goes by, those cells just replicate or produce a little bit more of themselves than the other cells, such that with many decades, you end up having more of those cells in your bone marrow than other cells. Think of it as an interest rate on your bank account and the compounding effect of that after 40 or 50 or 60 years. So it does tell us that these mutations can occur early and they just grow really slowly. And it sometimes relates to why some individuals feel as if they may have had symptoms related to the disease for many years. We don't quite know when all the mutations arise in all individual patients, particularly for some of the less common genes. In terms of why some individuals get the mutation in the first place, and those mutations, those cells grow in some individuals but not others, we think there are multiple factors. It could be the DNA that individuals are born with. So, in families, there may be susceptibility to diabetes or arthritis or other conditions. Similarly, it may be that the environment in one person's bone marrow is fertile ground for some of these cells to grow and expand, whereas in another individual's bone marrow, they're better able to suppress some of these clones. And it may also be lifestyle, inflammation, other factors we don't quite know yet, but the hope is that once we identify some of the factors either in our DNA or in our environment that can either predispose or protect, we can then start to bring that into the clinic and lead to advice for individuals, either patients or people within the healthy population.
That's wonderful. And the last question I'd ask really on this topic is beyond JAK2, MPL, CALR, oftentimes we're doing broader gene sequencing and finding additional mutations. Some of these sequencing panels involve hundreds of mutations, but are there other mutations that matter beyond just those three driver mutations?
Yes, you're right. And we do screen for more mutations in some individuals. So when individuals progress to more advanced forms of the condition, that can often be associated with the acquisition of more mutations. And they can arise in a whole host of different genes. And essentially what those genes are doing when mutated is they're making the cells a little bit more aggressive. Perhaps they're growing a little bit faster, and sometimes they can be associated with loss of function. Those cells don't work as well, perhaps, as they once did when they did just have those one of those three mutations. There are many researchers around the world who've really done a lot of work to try and understand which additional mutations are good or bad. And so what we can now do, there are many tools available where you can put in the mutations that you have, and you can understand whether you are more high risk or lower risk depending on your mutation profile. And that's how we sometimes use these in clinic. We sometimes use them for diagnosis, particularly if individuals don't have some of those key mutations, but other times we use them to try and anticipate what the future holds for these individuals.
Wonderful. Thank you.